Good morning. I'd like to call this meeting to order. My name is Ann Aiken. I'm the acting designated federal officer for NVAC, or the National Vaccine Advisory Committee. There are a few things you should know before we get started today. First, this is a public meeting and it's being recorded. All statements made today are on the record. Second, this advisory council is governed by the Federal Advisory Committee Act, or FACA for short. FACA provides rules about the circumstances by which agencies or officers of the federal government can establish or control committees or groups like this one to obtain advice or recommendations. The voting members are special government employees and are therefore subject to conflict of interest laws and regulations, as are all members who work for the federal government. These members previously provided information about their personal, professional, and financial interests. Each voting member's financial interest and outside affiliation has been carefully screened each year to ensure that they comply with federal ethics law. The liaison representatives are non-voting members of the advisory council and are not subject to the same FACA rules as the voting members. Additionally, the information provided at this meeting does not necessarily represent the official position of the National Vaccine Advisory Committee or the U.S. Department of Health and Human Services. Mention of products, processes, services, manufacturers, companies, or trademarks does not constitute its endorsement or recommendation by the U.S. government, HHS, or NVAC. So with that, I'm going to go ahead and proceed with roll call for the day. I'll take the official attendance and call off each of the names of the NVAC members, some of which are online and some are in person today. Please verbally respond when I call your name. Bob Hopkins.
Present, happy to be here.
Hello. Melody Butler.
Good morning. Happy to be here.
Thought I saw you there. We'll go back to Melody.
Oh, good morning. Can you hear me?
Yep.
I'm here.
Thank you.
Good morning. Happy to be here.
Good morning. Chris Arisman.
Yes, present. Can you hear me?
Yes. Good morning. Dan Hoff.
Yes, I'm here. Thanks.
Molly Hall.
Present.
Good morning. Jewel Mullen.
Present.
Good morning. Steve Rinderknecht.
Hey, good morning, present.
Good morning. Winona Stolzfus.
Good morning. I'm present.
Good morning. Keita Swami.
Good morning. Here.
Good morning. Bob Swanson.
Good morning. Here.
Good morning. Chris Regal. He may be running a little bit late. Claire Hannon.
Good morning. Present.
Good morning. Rebecca Coyle.
Present. Good morning.
Mitch Rotholtz, I don't believe is here, but he is scheduled to come. Erica McGowan. Dr. Judy Schley.
Present.
Good morning. Aaron Henry.
Good morning. Present.
Morning. Hannah El Sali. Hannah, are you on? We'll check for that. Justin Mills is not here yet. Kim Armstrong will be here in just a few minutes. Melinda Wharton, are you on? Okay. Mary Beth Hans. I think she's going to be running a little bit late as well. Nicole Sue.
Present.
Good morning. Corinne Bach.
Good morning.
Good morning. Brenda Holbrook.
Good morning, Ann.
Good morning. Uzo Chukwuma.
Good morning, everyone. Happy to be
Good
here.
morning. Andrew Ford.
Good morning.
Mandy Poust. And Troy Knighton.
Good morning, Ann. I'm here.
Good morning. Before I introduce Admiral Levine, I wanted to recognize the committee chair, Dr. Bob Hopkins, for his leadership on NVAC. This is his last meeting as chair, and I wanted to express my gratitude for all that he has done over the years, both in his role as the NVAC chair and in all the other very important roles that he takes on. He's been an exceptional chair, and I'm very grateful for the opportunity to work with him. Admiral Levine is going to recognize him and two other stellar NVAC members, Melanie Butler and Gita Swami, in her remarks. I've also really enjoyed working with both of these members. I've learned so much from both of you, and I thank you for your efforts on NVAC and the other professional work that you do. With that, I'd also like to thank the support team who plays pivotal roles in the management of the committee. This includes Rebecca Lazaration, Viola Jacobs, LaForest Dupree, Emily Downs, and Chloe Loving. It's Justin Lotus's first NVAC meeting over here, so welcome him, and Jennifer Adana as well, who's out at the registration desk welcoming people as they attend in person. I also wanted to briefly thank the studio team, tech support, and our sign language interpreters. We have 3 sign language interpreters helping to make the meeting more accessible, as well as a note taker. Both Kay Hayes and Tim Harrison, our office director and principal deputy director, provide consistent and thoughtful leadership to the National Vaccine Program. I want to officially thank them for their efforts. We also just hired a new deputy director of vaccines and immunization here in the office. Kim Scott, and many of you may know her. She's definitely been an NVAC, and she has 2 decades of experience in public health program management, policy, and evaluation, spanning the federal, state, local, and nonprofit sectors. And we are excited to have her on board. So welcome, Kim. And then I also wanted to introduce the ASH. It's a real pleasure to introduce her. She has some recorded remarks for us today. But as many of you know, she is the Assistant Secretary for Health at HHS and the Director of the National Vaccine Program. She has a rich clinical public health background, which really helps to inform the work that she does here at HHS. And she definitely is a vaccine champion and works to reduce hesitancy and misinformation. She encourages vaccination in a lot of activities that she does here. She is also very active in the health equity front and looks to really address missed opportunities in the immunization system. So with that, I will ask Rebecca to play her remarks.
Good morning. I am pleased to join you today to provide opening remarks. First, I would like to start out by thanking the committee members for your time and dedication to NVAC and to immunizations. I sincerely appreciate you and your knowledge and expertise. I also want to extend my thanks to Kay Hayes, the Director of the Office of Infectious Disease and HIV/AIDS Policy, and to Ann Aiken and the NVAC team for all that they have done to push this important work forward. To those watching in the room and online, welcome. As I speak to you today, summer is winding down, and it has been a hot one, with more than 200 U.S. cities and towns experiencing one of their hottest 5 summers on record. This summer, COVID-19 was also in the news. Athletes at the Olympics in Paris tested positive for COVID-19, and media outlets in the United States reported on surges of cases. So it was very timely last month when HHS unveiled a new campaign, Risk Less, Do More. This campaign will raise awareness of vaccines that prevent serious respiratory illnesses, such as COVID-19, the flu, and respiratory syncytial virus, or RSV. Though it's aiming to reach a broad audience, Risk Less, Do More will pay particular attention to those who faced increased chances of serious illness and hospitalization if infected with viruses that cause these diseases. This includes senior citizens, those living in long-term care facilities or in rural areas, and people who are pregnant or experience structural barriers in their access to healthcare information and services. You will hear more about the campaign during a presentation given by May Malik later today. The Risk Less, Do More campaign is one important part of a multi-layered approach from HHS to prevent respiratory diseases this upcoming season. This collaborative work in preventing respiratory diseases is very important. I want to mention the low vaccination rates we saw last season to illustrate this point. According to data from the Centers for Disease Control and Prevention, the preliminary influenza vaccination coverage during the last 2023-24 season was 57.4% among children 6 months through 17 years and 46.9% among adults. This is similar to the last season in children and actually a decrease of 2.5 percentage points from the prior season in adults. We absolutely need to do better in vaccinating everyone 6 months and older to protect them from the flu. While we all know that the flu can be deadly, especially for people with weakened immune systems, chronic diseases, and pneumonia, as well as young children and the elderly, not everyone realizes that risk. Last season, 44,900 people died from the flu in the United States alone. This is one reason why we need all of you to focus on educating people about the flu, influenza, its possibly heartbreaking or troublesome outcomes, and how we can prevent it. The same is true for COVID-19 and RSV, where we are also seeing less than desirable vaccination rates. Last season, a survey of United States adults found 4 key reasons for the low vaccination uptake of RSV, COVID-19, and flu. 1, a lack of provider recommendation. 2, concerns or issues with unknown or serious side effects. 3, mild side effects. And last, a lack of time or forgetting to get vaccinated. We all have a role to play in moving the needle, so to speak, on addressing these barriers to vaccination. I urge all of you and the rest of us in the vaccination and public health communities to work as hard as we can to address these barriers. There are a few simple steps everyone can take to proactively help do this. First, start with credible information. There are many places, including vaccines.gov and CDC.gov, to find credible information on vaccines, vaccine-preventable diseases, and answers to common questions. Both professionals and people who make an informed decision to vaccinate themselves or family members can use these sources to encourage others to also make informed decisions about vaccination. Once we are informed, I ask people to engage with others. These conversations don't have to be and really shouldn't be debates. If you share your knowledge and confidence regularly, you can help dispel myths and protect the people who are important to you. Support people where they are in their vaccination decision. This can be with additional information, requesting they speak with their provider to get their vaccination recommendation, or telling a personal story about how vaccination helped a patient or why you made the choice for yourself and your family. Finally, before I turn the meeting over to Dr. Hopkins, I would like to take a moment to express gratitude to 3 NVAC members who will cycle off of NVAC after this meeting. Dr. Bob Hopkins, Ms. Melody Ann Butler, and Dr. Geeta Swami. It is a bittersweet moment for me to say thank you and goodbye to Dr. Bob Hopkins, who has served as NVAC chair throughout my tenure here at HHS and beforehand. During this time, he has led the NVAC in addressing several important charges, leading to reports on vaccine confidence, vaccine safety, vaccine equity, COVID-19 vaccination, and a previous report to inform the development of the last national vaccine strategy. Dr. Hopkins has also ensured the timely inclusion of important topics during these regular NVAC meetings, where we have heard about the critical vaccine work for COVID-19, Mpox, and many other diseases. I truly appreciate his steadfast leadership, his overwhelming desire to make the vaccination system in our country stronger, and his dedication to helping people. Ms. Melody Ann Butler has also been an active and dedicated NVAC member. During her service, she has made key contributions to reports, recommendations, subcommittees, and meeting summaries. She also co-chaired the Immunization Equity Subcommittee, and I am very thankful for this incredibly important work. As many of you know, throughout my career, I focused on inclusion and equity, and in my current role, I am working to promote more inclusive data collection. This work directly relates to the recommendation Ms. Butler passionately advocated for during the development of the equity report. So thank you for this work and for your passion for immunization. As an infection preventionist and nurse and founding executive director of Nurses Who Vaccinate, Ms. Butler has brought a key frontline perspective to her work on NVAC. Finally, Dr. Geeta Swami has also served the committee with passion and expertise. As the only OBGYN, she critically leveraged her background in obstetrics and maternal fetal medicine, as well as her varied research expertise, to inform her careful and thoughtful recommendations and guidance. Her background also provided a foundation for developing advice and recommendations regarding the safety and efficacy of vaccines and identifying important areas of government and non-government cooperation that should be considered in implementing the National Vaccine Strategy, a subcommittee that she co-chaired. Given the important nuances and need to improve vaccination rates in pregnant people, her work has been critical to the committee. It will surely carry on through other members, but her absence will be felt by all. Thank you, Dr. Hopkins, Ms. Butler, and Dr. Swami, for all of your hard work serving NVAC. I wish you all the best in your continuing endeavors, and know that you will continue to work toward the better health of Americans. We've arranged for certificates of appreciation to be sent to you, and I hope you feel the appreciation in my remarks and in the room. Thank you very much for your time today. To our NVAC members and esteemed speakers, thank you for all that you do in your communities and at the national level through NVAC. Together, we are paving the way for a healthier future. Thank you for your attention today. I will turn it over to Dr. Hopkins for his remarks.
Well, good morning. Thank you for joining us for today's NVAC meeting. I want to thank you, Admiral Levine, for your remarks, and thank you, Ann, for getting us started, and to the NVAC team for its work in planning this meeting and supporting the committee throughout the year. I also want to thank the NVAC members and subcommittee members for their dedication to furthering the work of this committee. I look forward to the presentations and discussions today and tomorrow. And let's start with a few housekeeping items, and then we can move on to the review and approval of the minutes from the June 13th, 14th meeting, followed by a high-level overview of our agenda. In terms of housekeeping, I want to make sure that everyone is aware this is a public meeting and it's being webcasted on the HHS website. I want everyone to know that we have sign language interpreters available on the HHS live stream. We ask that everyone speak slowly and clearly to assist them in supporting our meeting. For our virtual participants, please remember to mute yourself when you're not speaking, and please don't use your camera unless you're presenting, asking questions, or answering a question. During discussion, I ask that all members and speakers, both virtual and present, identify themselves before speaking if I didn't acknowledge you by name and giving you the floor, and I try to do that. This helps the note taker and others to follow along. And throughout the day, there will be opportunities for committee discussion. And if you'd like to ask a question or provide a comment, either raise your placard or your virtual hand. The NVAC members previously received the meeting minutes from the June 13th, 14th, 2024 meeting. Do any of the members want to make any corrections to those minutes? If not, can I get a motion to approve those minutes?
Motion to approve.
Thank you, Dr. Swami. Can I get a second?
Second.
Thank you, Molly. All in favor, say aye.
Aye.
Any who decline? Our minutes have been approved. As always, members of the public can provide a public comment about 5 p.m. today and at 12:45 p.m. tomorrow. Public comments are not a question and answer session. They represent an opportunity for individuals who'd like to make a statement to do so. The deadline to request space for a public comment during this meeting has passed. However, anyone can submit a written comment up to 3 pages in length to nvac@hhs.gov. I'd like to spend a few minutes reviewing our agenda for the meeting. We have a wonderful lineup of speakers. Today, we'll start with a panel on universal hepatitis B vaccination recommendations and how to implement. We'll then hear about the new campaign Admiral Levine mentioned, Risk Less, Do More. And following this panel, we'll hear about 2 innovative vaccine equity projects. After lunch, we'll host a panel on evaluating vaccine equity efforts. Then we'll host 2 more panels on tuberculosis vaccine innovation and provider payment. We'll end the day with a working session on the national strategy charge and public comment. For tomorrow, we will open with agency and liaison member updates and a presentation on RSV immunization across the lifespan. After a break, we'll host a panel on HIV vaccine research and its use in vaccine development and immunization efforts. And we'll end the day with a working session on the national strategy charge and public comment. So we'll next turn to our first panel of the day. And as I provide introductions, I'd like to invite the panelists who are here in the room to come ahead and join me on the stage. Our first panel is called Actions for Elimination, Hepatitis B Vaccine Recommendation Implementation. Hepatitis B virus is a highly infectious virus, and people with hepatitis B often do not have symptoms during the acute infection. In 2022, CDC published universal updated recommendations from the ACIP, the Advisory Committee on Immunization Practices, on the use of hepatitis B vaccine in adults. Yet we're hearing there are system, physician, and patient-level implementation issues. In this session, we'll explore ways to improve the implementation of universal hepatitis B vaccine recommendation in adults. Our speakers include Dr. Melissa Nyandock from the Centers for Disease Control and Prevention, Mitchell Luce from the Forum for Collaborative Research, Darcy Cherlin from the U.S. Department of Health and Human Services, Dr. Judy Schley, an NVAC member who works at the Denver Public Health, and Dr. Kelly Moore from immunize.org. Dr. Nyandock, the floor is yours.
Good morning. Is everyone able to hear me okay?
You are loud and clear. Please begin.
Thank you so much. Hi, I'm Melissa Nyandak. I'm with CDC, Division of Viral Hepatitis, and happy to be here today. Next slide, please. So viral hepatitis continues to be a preventable but significant public health crisis globally and in the US. And we have missed opportunities along the care cascade, which could interrupt liver disease, cancer, and death. There's an epidemic of undiagnosed infection in the US for both hepatitis B and C, and there remain people entering the risk pool each year where infection could be decreased through prevention, including vaccination, screening, and treatment. Next slide, please. The Hep B immunization strategy has impacted Hep B incidence. That is to say, that among people born in the US, among certain age groups, there is a lot of protection. For example, the 1991 birth cohort would be 33 years of age, and the catch-up recommendation in 99 would have extended vaccination to people born at or after 1981, or these people would be 43 years old now. However, there are populations who have been missed out on birth or catch-up dosing. Thus, understanding who we are missing and why is central to build in opportunities for person-centered integrated care strategies. This includes reaching people born outside the US where birth and infant vaccination practices are at earlier stages of implementation, resulting in higher rates of chronic Hep B. And there's also higher rates of new infection due to syndemic consequences of injection drug use among people with IDU or among people with history of STIs and multiple sex partners. Next slide, please. Continuing along these lines, here are some recent reported cases of Hep B by age group, and you see the drop-off of acute Hep B in that younger age group benefiting from vaccination, and then some lag in the upper age groups. On the right, I highlight the syndemic consequences of drug use, really showing the risk factors for Hep B by risk exposure. And the associated consequence for infectious consequences rises to the top with injection drug use, underscoring an important opportunity to provide integrated services for people who use drugs through MAT programs, syringe service programs, and/or carceral settings. as well as providing care and vaccination opportunities for people with HIV or other STIs. Next slide. I take this opportunity to show the picture for hepatitis C to make 2 points. One, hepatitis C incidence continues to expand across all age groups, largely driven by injection drug use. And two, risk factors for hepatitis C overlap with those for acute hep B shown on the prior slide, underscoring an important opportunity to provide integrated services for people who use drugs. Next slide. So back to hep B. For hep B, we see two distinct and sometimes overlapping epidemiologies. Understanding the epidemiology will lead to tailored solutions to reach people disproportionately impacted. Next slide, please. In terms of chronic hep B morbidity, on the left you see the rate of chronic hep B was highest among persons between 30 and 49, which accounts for 47% of all chronic hep B cases reported in 2022. On the right, you see the rate of hep B was highest among non-Hispanic, Asian, and Pacific Islanders, and was 11 times the rate of non-Hispanic white persons. Next slide, please. Similarly, this slide depicts mortality by age and race and ethnicity, and it really highlights who we are missing, that we are not getting folks into care early enough. There's missed opportunities for vaccination and treatment and then eventually treatment for chronic hep B, and missed opportunities to prevent transmission. On the right, what you see in 2022, the hepatitis B related mortality was highest among non-Hispanic, Asian Pacific Islanders, and it was 8.5 times the mortality among non-Hispanic white persons. Next slide, please. So as you know, we have several strategies to eliminate hep B in the US centered on screening, testing, and vaccination. Next slide, please. I want to just quickly go over the screening recommendations. The new hepatitis B screening and testing recommendations, which CDC issued in March of 2023, calls for everyone to get screened at least once in their lifetime and lowers barriers to testing for those who need it most. The 2023 hep B virus screening and testing recommendations are to screen all adults 18 and older at least once in their lifetime, screen all pregnant people during each pregnancy, regardless of vaccination status or history of testing, and periodic risk-based testing to include people who are incarcerated, people with a history of sexually transmitted infections or multiple sex partners, and people with hepatitis C. And of course, test anyone who requests hepatitis B testing, regardless of disclosure of at risk. Children and adolescents are already included and are not shown on this slide. Next slide, please. And I just wanted to highlight quickly that in 2023, there is this expanded risk section to ensure that people are getting screened. Next slide, please. So with respect to vaccination, CDC continues to promote the longstanding guidance of the Advisory Committee on Immunization Practices, or ACIP, which recommends all infants and unvaccinated children under the age of 19 be vaccinated against hep B. What's new in ACIP recommending near universal vaccination coverage in the older age groups, and this is from 2022 as mentioned. Specifically, the recommendations are to have all adults aged 19 through 59 of age vaccinated against hep B, and to vaccinate adults 60 years of age and older with risk factors for hep B, as previously discussed, and also adults 60 and older without risk factors for hep B, but who seek protection against hep B may also receive the vaccine. Now, I know this panel is a little focused on the implementation. So with the newer guidance for screening and vaccination of adults, several implementation questions have been raised and are addressed in the guidance. This is especially relevant for point of care settings to increase efficiencies between screening and vaccination among people with decreased engagement in the health services. As shown on this slide, per the recommendations, after the collection of blood for a triple panel screening, people who have not completed the hep B vaccine series should be offered vaccination per the recommendations at the same visit or an associated provider visit. It is not necessary to wait for the Hep B screening results to administer the first vaccine dose. However, blood should be drawn before the vaccine is administered. Next slide, please. Oh, sorry, I might have been off one. Next slide, please. Thank you. So 2 quick slides on the perinatal Hep B prevention program, which highlights good practices to work with local jurisdictions to screen and connect women and their babies with Hep B services. This is a good example of coordination across health delivery points in coordination with laboratories. Next slide, please. The steps are shown here, and there is, of course, maternal screening with each pregnancy. This provides an opportunity to link a mother to care, as well as provides the opportunity for prevention of mother-to-child transmission. Infant vaccination for infants born to hepatitis B positive women is shown as the next step. And then earlier testing may detect and maximize the likelihood for detecting late HBV infection. Finally, I highlight these steps because they're very checklist oriented with clear deliverables and will impact Hep B incidence among babies born to mothers with Hep B and allows the mother to be linked to care. Next slide, please. Next slide, please. Thank you. I thought to end with the last 2 slides on syndemics. As person-centered health really requires us all to be thinking across disease silos and work to develop programs with equitable access. Not doing so results in missed opportunities across many diverse entry points to care. Next slide, please. So how we might do this, and this is my final slide, as we work to implement the Hep B prevention and vaccination guidelines, we need to lean into integrated person-centered solutions to improve outreach to impacted communities. Here's a couple next steps. May include improved awareness among providers, such that providers feel comfortable ordering and interpreting screening results, leading to vaccination. Patient education, that is in a shared language from trusted sources, will be needed to encourage uptake of screening and vaccination. With expanded screening and vaccination at diverse entry points to care, there's a need to develop setting-specific guides and practices. There's many best practices out there around electronic medical alerts, and we should be learning from these. Laboratories can assist in this effort by supporting the development of Hep B lab panels that include the triple screen with a clear summary and interpretation of the result. Policies should be considered to streamline hepatitis B screening reimbursement by eliminating the requirement for providers to report Hep B screening with an additional ICD-10 diagnosis code for risk behaviors. This is a step that may be easily overlooked and providers may be reluctant to enter. And finally, there's the future potential for the United States Preventative Task Force alignment, which will be key in further coverage. These steps are just meant to be high level and only a start, and CDC recognizes that partners are already hard at work planning the implementation of these guidelines in different settings. Thank you for the opportunity to speak today.
Thank you, Dr. Doc. Our next presenter is Mitchell Liz from the Forum for Collaborative Research.
Good morning, everyone. Thank you for the invitation. My name is Mitchell. I'm a research associate with the Forum for Collaborative Research, and on behalf of Dr. Veronica Miller and all of the forum, thank you very much for the invitation to present. I'll be speaking today about our symposium that we helped convene, which was focused on supporting hepatitis B elimination and universal HBV adult vaccination in the US. Just to provide some context for where we are coming from, the Forum for Collaborative Research, or the Forum, is based out of the School of Public Health at the University of California, Berkeley, but we have an office here in Washington, D.C., and really our focus is on helping accelerate drug development and regulatory science for unmet medical needs. We have a number of disease area programs that we address, including hepatitis B, and our model is such that we provide an independent and neutral venue for ongoing multi-stakeholder dialogue in which each stakeholder group has an equal voice at the table as it relates to decision making in regulatory science and drug development. On the left, you'll see the different stakeholder groups that we engage with in this sort of model, and this includes academicians, clinicians, pharmaceutical companies, diagnostic companies, payers and funders, regulatory authorities, importantly, international organizations, and of course, the patient advocate and community representative community. And so really this model is very effective in helping to facilitate consensus building, which is really key for accelerating the regulatory path for different drug development, helping to increase clarity, collaboration, and innovation. And so while drug development is one focus of the forum, that same model can be applied in a series of projects that we've convened under our policy series. And really the focus of our policy series is supporting implementation of national health policy with respect to HIV and viral hepatitis, testing, prevention, and linkage to care. So this is a series of meetings that we have convened starting all the way back in 2008 with a series of national summits on HIV testing. We then expanded our focus to hepatitis C. And in 2022, we convened a full day meeting, symposium, really thinking about how do we support the ACIP guidance towards universal adult hepatitis B vaccination in the US. So just to hone in on this symposium, it was held on November 1st, 2022. Just want to note that this was before the screening guidance came out in 2023. And really, again, the objective was to apply that multi-stakeholder convening model to support ACIP guidance and convene discussions towards strategizing how can we implement universal adult HPV vaccination, really with a focus on highly impacted settings, thinking about those groups that are at higher risk for acquiring acute HPV infection. This symposium was a full day meeting, and we convened around 110 expert discussants from different stakeholder groups, government agencies, professional societies, health departments, folks from the harm reduction space, as well as community-based organizations. And leading up to the symposium, we facilitated a series of stakeholder consultation meetings with key opinion leaders to really think about what are the needs and priorities of different stakeholders, what are the things that we should focus on in this full day meeting. And we extend our gratitude to our colleagues at the Division of Viral Hepatitis at the CDC, who had a very strong hand in helping to shape the program agenda. So some of the things that we'd like to highlight that were discussed at this full day meeting, I encourage folks to look at our publication that was published in the Journal of Virus Eradication that will provide a little bit more detail about what was discussed at this meeting, but just to highlight 4 major points that were discussed as it relates to implementation strategies. The first was really around how do we leverage the electronic health record. We had lots of folks from different clinical settings sharing their experiences with strategies that they've used to really innovate their electronic health records to support their providers in performing hepatitis B screening and vaccination. So one of the first points was that we had a great talk by Dr. Amy Krawiak at the California Correctional Healthcare Services, who shared that they have implemented HPV specialist real-time messaging and referral systems within their electronic health record. And Dr. Krawiak had said that this sort of real-time messaging done through the EHR was really effective at helping providers who might not have as much information about hepatitis B. So we have the real-time messaging. Also, routine opt-out screening for hepatitis B, HCV, and HIV was something that was very effective within their correctional healthcare facility. Another feature that they used in their EHR was this one-click button for ordering the HPV serology tests. It just makes it, very easy for providers. With one click, they order the 3 different serologies. They called it an order set in their EHR. Another thing not visualized on the screen, they had something called HPV Power Plans, which were basically just a collection of clinical guidance documents that providers could refer to if they had any questions about, treatment algorithms or screening algorithms. So that was also a very effective tool in their toolbox within their EHR. So another major point of discussion throughout the symposium was this idea of embedding HPV healthcare services in diverse healthcare delivery settings, sort of thinking about syndemic approaches. We had Dr. Stacy Truskin, who at the time was working with the Philadelphia Fight Community Health Center. She was a big advocate of de-siloing healthcare, de-siloing, different diseases. And so trying to integrate HPV healthcare services into incarcerated settings, harm reduction settings, and especially as well rural settings. And so with the embedding HPV healthcare services, the routine opt-out screening was found to be a very effective mechanism for increasing implementation. We also had a lot of discussion about sort of funding mechanisms. 340B, as well as the section 317 were big points of discussion. I am by no means an expert on these things. They're a little bit complicated, but the strengths and limitations of these different funding mechanisms were definitely discussed. And so we had lots of health department colleagues, sharing about their experiences. How do we really utilize and capitalize on, the 340B program to increase implementation. And there's sort of an acknowledgement that while helpful, these programs also have their limitations as well. The last point that we'd like to touch on is really this idea of building vaccine confidence at the community level. Of course, it is incredibly important to engage with communities, develop culturally appropriate messaging, and meaningfully, build trust with communities at risk. And so here we engage many different community-based organizations, one of which includes the Hepatitis B Initiative of Washington, D.C., participated and shared about the really innovative work that they're doing in the DMV area. One strategy that they've used that has been very successful was around really employing and hiring trusted community leaders, paying them and really partnering with them to take the lead on HPV health education at the community level, and then working with these trusted community leaders in spaces where communities, gather. So thinking about, different markets was one thing, but also, spaces of faith, to think about how can we implement community health screening events and vaccination events in these spaces. And so these are some of just the key discussion points, definitely more discussed in our publication in the Journal of Virus Eradication. And I encourage folks to take a look and really see there's a lot of really good richness. With that, we just like to recognize we had a scientific planning committee that really helped in the planning of this meeting, one of which includes Dr. Kelly Moore. So thank you so much, Dr. Kelly Moore. We'd like to just acknowledge our sponsors for helping make this symposium possible, as well as our convening partners. And thank you very much for your attention.
Thank you very much, Mitchell. Our next presenter is Darcy Cherlin from the U.S. Department of Health and Human Services.
Hi, everyone. Can you hear me all right?
You are loud and clear. Please proceed.
All right, great. Well, hello, I'm Darcy Cherlin, a public health analyst at the Office of Infectious Disease and HIV/AIDS Policy in the Office of the Assistant Secretary for Health within the U.S. Department of Health and Human Services. Grateful to be here today with you all to share how our office has been working across the federal government to coordinate the implementation of the adult hepatitis B vaccine recommendations. Next slide, please. So today I'll be sharing an overview of the report to Congress that OIDP developed in partnership with the CDC And this includes the progress that OIDP and many of our federal partners have made coordinating and implementing the updated hepatitis B recommendations. And I'll also take some time to discuss opportunities we've identified for increasing the implementation of these recommendations if resources were to become available in the future. Next slide, please. We received a request from Congress to lead a government-wide coordinated effort to implement the updated recommendations on hepatitis B vaccines in adults and to produce a report in this effort. Next slide. So as part of our coordination role, OIDP led the development of the 2021 to 2025 Viral Hepatitis National Strategic Plan and the Vaccines National Strategic Plan. OIDP collaborates with representatives from agencies across the federal government to transform these strategic plans into action. Increasing hepatitis B vaccination uptake and including hepatitis B in adult vaccination services are key strategies that we work with our partners to implement. OIDP also coordinates and convenes a syndemic steering committee to bring together federal leaders to address the syndemic of HIV, viral hepatitis, STIs, and substance use disorder. Next slide, please. So when the updated hepatitis B recommendations were published by the CDC in April of 2022, OIDP started meeting with federal agencies to discuss how they would implement the new recommendations into their programs. And we held a webinar to share these plans with the public on May 23rd of 2022. We went through a similar process when the universal screening recommendations were released and held a webinar on May 30th of 2023 that included federal updates on the implementation of the hepatitis B vaccination recommendations into their federal programs. Both of these webinars were recorded and are available on our website. Next slide, please. So a lot of work has been done across the federal government to facilitate the implementation of these recommendations. And these are listed on the right of my slide, and I'll highlight a few of these today. So the CDC, through 2 different grants, provided fiscal year 2023 funding to 17 state and local health departments and syringe service programs to support hepatitis services in high impact settings, including hepatitis B vaccination. CMS proposed to expand coverage of hepatitis B vaccinations under Medicare Part B by covering individuals who have not previously received a completed hepatitis B vaccination series. The FDA initiated the process to reclassify hepatitis B virus assays from Class 3 to Class 2. With this down classification, it could be easier for new hepatitis B diagnostics, such as point-of-care tests, to become available in the United States. A point-of-care test for hepatitis B would allow practitioners to identify if someone needs a hepatitis B vaccine and then vaccinate in the same day. Next slide, please. HRSA's Ryan White HIV and AIDS program conducted provider training on hepatitis B prevention and the updated vaccination recommendations. IHS implemented a clinical decision support algorithm which forecasts recommended vaccines for individual patients using the most up-to-date ACIP vaccine recommendations. And the VA updated their guidelines and now offer hepatitis B vaccination to previously unimmunized veterans in care aged 19 through 59 years. Next slide, please. So that is just some of the work that was accomplished at current funding levels by our federal partners. We've also been working with agencies to identify opportunities for increasing hepatitis B vaccination if resources and funds were to become available in the coming years. These are listed here, and I'll go into some details about each of these on the next few slides. Next slide. Enhanced government-wide coordination has the potential to increase hepatitis B vaccination. Currently, no funds have been dedicated to conducting and sustaining viral hepatitis coordination activities across the federal government. With dedicated resources, we could conduct a public awareness campaign, increase stakeholder engagement, and policy alignment and funds could also be used to support development of metrics to measure impact and progress. Next slide, please. There are also opportunities around funding vaccines and other viral hepatitis services that could increase vaccination uptake. So currently, the resources available for states to purchase adult vaccine are limited. Although agencies do provide funding to support viral hepatitis services, the funds cannot be used to purchase vaccines, hepatitis B vaccines. Funding the Vaccines for Adults program would support the procurement of vaccines and increase hepatitis B vaccination for adults who are uninsured. Insurance coverage for screening and testing is another opportunity. Currently, Medicare coverage for hepatitis B screening is limited to people at risk. Expanding Medicare coverage for hepatitis B screening to be in alignment with CDC universal screening recommendations would ensure that patients know their status and susceptibility, which can lead to an increase in uptake of the hepatitis B vaccine. And funding syndemic approaches, as we've heard and by our last two speakers, supporting programs that provide whole person care can increase opportunities for hepatitis B vaccination in non-traditional settings. Next slide, please. Increasing the use of immunization information systems and health IT tools is another opportunity. Currently, data of hepatitis B vaccination uptake is very limited. Increased use and interoperability of immunization information systems would enhance data quality and monitoring and measurement of hepatitis B vaccination coverage rates. Additionally, development and implementation of EHR clinical support tools and dashboards have been shown to be effective. Next slide, please. Finally, there is a need to build capacity in federal and federally funded programs for personnel to administer hepatitis B vaccines, to provide education, training, culturally appropriate messaging, and community outreach initiatives. Next slide. That concludes my presentation. If you're interested in learning more about any of these activities I discussed or topics, please don't hesitate to reach out. Thank you for your time.
Thank you very much, Darcy. Our next presenter is Dr. Judy Schley from Denver Public Health.
Yes, hi, everybody. My name's Judy Schley. Hello from colorful Colorado. Sorry, I'm not there with you all. So I represent the NACHO, which is the National Association of County and City Health Officials. And so I wanted to talk a little bit about what local public health departments are doing to increase hepatitis B vaccination. Next slide, please. So first, just to give an overview of NACHO, it is a national organization that serves more than 3,300 local health departments across the United States, and really is focused on providing cutting-edge skill building, professional resources, and programs. And the mission is to improve the health of communities by strengthening and advocating for local health departments. And you can see here on the right the various areas of focus that NACHO has done and is doing. Next slide, please. So what I'm going to do is talk about some of the practical things that local public health has done in terms of the various approaches they have been using in terms of hepatitis B vaccination, some community-based events that have been done to include hepatitis B vaccines, and then what health departments are doing to promote and provide Hep B through to adults with health systems, and then some innovative things related to healthcare for the homeless clinics, and how they've been doing that in Minnesota. Next slide, please. So first off, in 2023, NACHO put out an immunization profile study. And in that, they compared what they had found in 2017 to 2022 data, which is reported in 2023. And as you can see, outreach in terms of what the conducted activities were in 2022, you can see increases in social and traditional media focuses, community outreach and education, outreach efforts for adults, and then it goes down the list. But outreach to adults was a significant improvement, as well as community outreach and media focus. Next slide, please. In terms of in this same report, the top 3 immunization program priorities for the next 3 years, this was reported from 2022 in the 2023 report, you can see that confidence and hesitance for routine adult immunizations was lower than some of the other things that have been a focus of health departments, in particular youth and childhood vaccine, as well as outreach and education to community partners. I will say that when you outreach to community partners, you can include all the vaccine preventable diseases, which can include hepatitis B. And of course, when you're talking about youth and childhood vaccination, it includes families. So in some sense, it has a relationship to adult vaccinations. Next slide. Now, I want to just call out what public health has been through us since 2022, and it started before that with the COVID pandemic. We have had tremendous problems with outbreaks. And I even forgot one on this list. So the COVID vaccination campaign, which really was really paramount to helping our country, and local public health was integral in making that happen. And then after that was sort of settling out, then we had the Mpox outbreaks, and we had to uplift all the vaccination efforts. That was really paramount to avoid that outbreak. Then in communities throughout the country, we've had hepatitis A outbreaks, meningococcal outbreaks. In Denver, we had it in people experiencing homelessness. And then, of course, we heard in the last meeting in June about measles and what happened in Chicago, but it's happened in other parts. And one that I forgot, which as I was preparing last night, I realized in Denver, we had a varicella outbreak in January. And all these things are competing demands that make it so we can't prioritize creation of routine approaches to adult vaccinations. Next slide. What I wanted to highlight and things that I have the locus of control over is to describe what we do at the Public Health Institute of Denver Health, which is where I work, which is part of Denver Health, and then discuss what we've done at Denver Health with a best practice alert. So first off, in our Public Health Institute, we have we have a team that does outreach activities, and we go to community programs, we go to schools, we go to substance treatment locations, we go to housing authority, all of those places. But in particular, in substance treatment locations, we go regularly and we provide hepatitis B vaccinations to clients who are seen in those locations. And that's been quite helpful in raising the vaccination rates. In terms of our infectious diseases clinic, we have, which is co-located next to our immunization clinic, we have HIV and Hep C treatment that is provided in those clinics. And we did a lot of work to ensure that we could get the Heplisav vaccine for those patients, because that is considered the preferred vaccine. And so we had to work through to get that implemented. We did a workaround until we got it so that the organization allowed us to do it. Now that's a more expensive vaccine, and so what we've had to do is only provide it to people who have a payer source, because Denver Health is a safety net institution, and so it doesn't have unlimited resources for people who are uninsured or underinsured. So we have now set that into motion, and the majority of people, in particular who have HIV, have a payer source, and we can be able to offer that vaccine in our clinics. We also did a lot of work. We and rest of the country in a number of places had a lot of newcomers that came to the United States. And so we did a lot of work, partly because of our varicella outbreak. But what we did when we went to community events, we brought all sorts of vaccines that are available, not just varicella, which could be given to adults and to children, but also all the vaccines, so we could update the vaccines and complete vaccination series as close as possible, and then putting that into our IIS system so it would be communicated to the rest of the state of Colorado. In that efforts from public health, we have given over, in 2023, we gave almost 1,200 vaccines through these efforts that we're very proud of. In Denver Health, in 2022, we created a best practice alert. And this is something that I know is very important. we decided as an organization, because of the cost of the vaccine, for the Enterix vaccine, which is the one that we use at our organization, we could not provide it to universal vaccination efforts, but instead we prioritized it to a certain subset of the population. That includes people who have started the Hep B vaccination, and so we complete the series, and then we prioritize people who have HIV, any person with any type of liver disease, and people who inject drugs. And what we found is that we, in 2023, gave almost 5,500 vaccines of hepatitis B. So that was a good start. We would like to do universal vaccination, but of course, it's a prioritization of resources, so we can't do that at this time. Next slide. In terms of other local public health efforts, I got a smattering of things from our immunization work group that were describing what they do. One in Orange County, New York, they offer vaccines and including hepatitis B at their sexual health clinics, which is a recommendation that we've heard earlier as being an important group. In Madison County, New York, they have been providing education to women in various settings, and that includes then the families and themselves to be able to get vaccinated through the county jail and partnering with organizations that take care of pregnant women, as well as through prenatal services group. The other thing that they did was they had an outbreak of hepatitis A in a halfway house, and what they did is they provided hepatitis A and B vaccination as a way to take care of that and help that. And then finally, in Minnesota, they have healthcare for the homeless clinics, and they do an assessment and provision of hepatitis B vaccination as part of that care. Next slide. And finally, I just want to talk about the challenges that public health has in terms of taking care of people who have come to local public health for services. So in terms of insurance coverages, most local health departments bill public insurance, but few of them bill private insurance, which limits the ability of people to get reimbursed for those services. And then, of course, local public health is a safety net for communities. And so many people who come to local public health departments or to their services are uninsured or underinsured. And we have seen a tremendous decrease in the amount of 317 funds, which limits the ability to have hepatitis B vaccines available to provide. And I do, when Darcy spoke about the Vaccine for Adult program, it is really sad to be able to go out to community events and not have adult vaccinations for people who are underinsured and uninsured. And so to have that type of a program where we could actually provide all the necessary vaccines for people who need them, and we would love to give them to them, would be a wonderful thing. And lastly, in NACCHO's 2020 survey, they did, this is before the universal vaccination requirements were implemented through this ACIP, but nearly 3/4 of the respondents indicated that funding is a barrier to the provision and scaling up of hepatitis services. And most health departments have inadequate funding and often no funding for the prevention and control of hepatitis. So my last slide is just my contact information, and I look forward to questions from the panel. Thank you.
Thank you very much, Judy. And our final presenter in this panel is Dr. Kelly Moore from immunize.org. Kelly, you have the floor.
Thank you very much. It's good to be with all of you. I'm batting cleanup, so I will hit some of the highlights of things that we haven't already gone over or dive a little deeper where needed. And my focus today is going to be on the practical clinical issues related to implementation of universal adult hepatitis B vaccination, or really, as I call it, it's an adult Hep B catch-up program, because we've already gotten all the kids and the young adults, and really this is just catching up older adults. So my first slide is just where are we now? As a reminder, that as CDC spoke earlier, they're focusing on a simultaneous implementation of both vaccination in adults through age 59, as well as the screening program, a recommendation for one-time screening at least of everyone 18 and over. And this is sort of being implemented. As you may have noticed in the comments, we have not seen a change in adult hepatitis B vaccination coverage, despite the fact that these recommendations for vaccination are now over 2 years old. One of the things that's a challenge is shifting the mindset of people from a risk-based recommendation to something that is universal, and the concept that everyone can benefit from knowing their status and being protected. So some of the clinical challenges, and I will acknowledge I don't practice clinical medicine, but I am speaking on behalf of, in part, of my colleague, Dr. Cami Graham, who is at Beth Israel Deaconess Hospital and couldn't be with us today. And she has helped prepare these slides to highlight some of the issues at the clinical level. So just a few of the clinical challenges for folks. One of them, and these are really operational practical issues. One of them is that younger adults likely were vaccinated in childhood. As you heard, we've had recommendations in place since 1991. So people into their early 30s were exposed to routine childhood recommendations, although when they are screened under the universal screening recommendation, they're very likely to have a negative antibody titer because it's natural that those titers decline gradually over time, and it's very typical that a good proportion of them will have negative titers, but they were vaccinated. And if we know they were vaccinated, the recommendation to the clinician is do nothing. Unless they're in a high-risk group, such as a healthcare professional who needs to be absolutely sure that their titers demonstrate they're protected, they are not to do anything for someone who was known to have been vaccinated and now has negative titers. The reason is, clinically, these people don't show evidence of acute clinical infection. If they are exposed and infected, they don't go on to develop chronic hepatitis B disease. So we feel comfortable, this has been the long-standing CDC recommendation, that you don't need to revaccinate someone who has documented history of vaccination. But that cognitively is difficult for clinicians to do, because the main reason they've screened people for years has been because they needed to know if they needed to revaccinate or give a challenge dose, because they were someone who, by definition, they were getting screened because they were at high risk. So this is an area where there's some confusion and paralysis about just what to do, because there's some discomfort with the idea that their titers are negative, but you're not doing anything. You're just reassuring them that you know they were vaccinated and therefore they're protected. Other issues that can complicate the clinical process is the lack of vaccination records, because the hepatitis B series is needed for almost all people, only once in a lifetime, and missing records, especially with childhood programs, and now people are adults in their 30s and 40s, is records are unlikely to be located. So that is complicating issues for folks and creating frustration. And then finally, there's the truly limited provider awareness and motivation around implementing this program, because I think there's a lack of understanding of why we have a universal routine catch-up recommendation for these adults. They're not necessarily seeing the damage that hepatitis B virus infections cause. It's more silent, unlike something very visible like measles. It slides below the surface, causing death and disease without making much noise. And so people don't necessarily realize, even clinicians, that anyone can be exposed to hepatitis B and everyone can benefit from being protected. So those are all challenges. But then one of the biggest challenges right at the moment, and it's been touched on by previous speakers, is figuring out how to integrate screening and vaccination, especially when the CDC recommendations for vaccination are covered under the Affordable Care Act, and other provisions make sure that vaccination is a covered benefit for people who have Medicaid, Medicare, or an ACA compliant health plan. It's covered under the Vaccines for Children program. However, screening of people who are not at risk for hepatitis B, as we heard, is not approved at this point by the U.S. Preventive Services Task Force. Therefore, it's not necessarily covered by health insurance. So you have folks who are doing their best to do as CDC recommends, which is draw blood for screening and administer the first dose of vaccine, send in the tests, and then based on the results of those tests, either complete vaccination or suspend vaccination because the test came back showing, yes, they had a previous history of hepatitis B infection, for example. And yet they're getting a rejection on the billing charge for the screening test. And so that complicates a health system's efforts to implement these simultaneous recommendations as CDC would like to see them implemented until we resolve the insurance coverage issues. So that is really a big operational challenge for folks. So we recently, Dr. Graham and colleagues and I, including Dr. Nina Kim at Washington, published a paper on EHR system prompts, because another issue with EHR system prompts for vaccination and screening are that they're a great idea, but they have to be done properly. And in talking with colleagues, we found that in some settings, system prompts are not prompting in a way that follows ACIP recommendations. One health system said their system only prompts for diabetics and no one else. And in fact, there were prompts that were dumb prompts, if you will. They were not informed by the fact that the patient had lab results showing a previous history of hepatitis B infection or a history of vaccination. And so clinicians would be seeing prompts that they knew didn't make sense for that patient, and then they tune them out. They just click through and tune them out. So you have to do a prompt properly. And the paper we published went through the logic of those prompts in order to help support health systems in doing this well. Here's an example of a hepatitis B prompt from a health system where when it automatically, if you're looking in the immunization schedule, has the prompt ready to order a hepatitis B vaccine. In this case, it's pre-selecting the vaccine that's used by their health system primarily, but it offers all the vaccines because in certain situations you may choose a different product for that patient, but it just makes things easier for the clinician if it's done well. The vaccination workflow, if feasible with an EHR system, is very simple. When the person is of the proper age, 19 through 59, the system looks and says, do they have a history of vaccination? If no, then they also look and see, do they have a history of hepatitis B infection based on their lab tests? If no, then vaccination is prompted. For people who are 60 and over, the only caveat is at the end of that assessment, they also look for other risk factors. If there are no other risk factors, then ideally the recommendation is you may vaccinate. And some health systems may choose to routinely offer vaccination even to those 60 and over, and that's perfectly acceptable by CDC. Our paper also covers a number of frequently asked questions that clinicians often have. And in addition to that, we sent out before the meeting some resources from immunize.org. One, a Q&A document for clinicians who are looking to implement hepatitis B vaccination and screening. Another one-pager for patients that explains the value of vaccination and screening as 2 steps to protect themselves from serious liver disease for life. But one of the most important ones is this last one. Can they conduct a vaccination program without doing screening? And given the complications with insurance coverage for screening, by all means, the answer is yes, do what you can, especially if you think of pharmacy settings where we don't have point of care screening tests. Pharmacies are only offering vaccination and are going to refer out to screening. These recommendations are related, but they're independent. They don't depend on one another. And if we're going to get the high levels of vaccination that we need to remind people that if all you can do is vaccinate, that's fine. We'll screen them later when we're able to do so. Another issue that comes up related to this is helping people understand in the clinical community the interpretation of hepatitis B vaccine serologies. This is a table that Dr. Graham developed for another paper that she had written that gives people simple instructions based on what the triple screen results are and what one should do related to vaccination. And this kind of very simple information is what clinicians need in order to implement hepatitis B vaccination catch-up program for all adults. So in conclusion, we have national goals that have already been established, and that is critical. It gives us a target to aim for and a mission to get people focused on. But we need additional actions to achieve this successfully. We need clinicians all to understand, and the public, that you never know when you're going to be exposed to hepatitis B vaccine. To credit Marla, yesterday in one of our conversations, you never know, but everyone can benefit from knowing their status and being protected. We're simply offering to adults the same benefit we've been offering to children since 1991, and that is to catch them up with hepatitis B protection. And so if we take this as a campaign mindset, this could be accomplished and done in 3 to 5 years. And this doesn't need to be carried on for years and years and years. But in order to do so, we're going to need to have alignment of the U.S. Preventive Services Task Force recommendations to support the screening against hepatitis B so that we can get insurance coverage for that. And in addition, we also need to use IISs to ensure that people are only getting the vaccination they need one time, and then clinicians thereafter are able to access that history of vaccination and not worry about catching up people that are already taken care of. So those are just a few things that we can do to better implement the hepatitis B vaccination recommendations and achieve elimination of this very vaccine preventable disease. I want to thank you and also continue to acknowledge Cami Graham and Michaela Jackson, who helped prepare the presentation today. I speak on their behalf, and I look forward to your questions.
Thank you very much, Kelly. I want to thank all the members of this panel. Are there any questions or comments from the members of the committee, either here in the room or online? Mitch, please.
Thank you to the panel for a great presentation and great insights in terms of what we're trying to do. And Kelly, your last comments really hit on where I was thinking too. We really want to try to increase access. We really also need to look and explore what are the barriers for providers for getting that access. So for example, you had mentioned pharmacies being a good source. But one of the barriers that pharmacists deal with is every state has different authorities for what vaccines they can administer. So an analysis and efforts to try to change those, expand those authorities is important, but also the coverage of pharmacists administering the vaccines is limited. For example, in Medicare, now there's some changes hopefully in 2025 that are coming that will allow pharmacists to actually under Medicare Part B administer hepatitis B vaccine to patients with diabetes. Right now they can't. So there's actually a barrier there specifically for pharmacists being able to do that. They're providing diabetes care, but they can't then go to the next step of making sure those individuals get vaccinated. And then we also should look at point of care testing. Across the whole healthcare spectrum, there's a lot of confusion and concern by healthcare providers. Why am I vaccinating and testing? I don't understand the reasoning between how that all comes together. So I think we all need to do a better job of explaining that and trying to see why that is a benefit to the public health. But thank you for the insights. Hopefully, more discussions can occur to overcome some of these barriers.
Any comments from members of the panel?
Only that I concur with Mitch and the focus on screening and vaccination done together works in the medical office setting, but it doesn't work in pharmacy settings at this stage. And that is, as we know, a really important point of access. And the issue is we have a universal recommendation through age 59. So there are a lot of people who are not on Medicare, but who are commercially insured who could be benefiting from vaccination in pharmacy settings. And the one-page document that we developed on screening and vaccination is intended to be given to patients to say, you may be vaccinated now, but you still need to be screened at some point later to make sure that you don't have a history of infection. And so we need to look at the art of the possible. What can we do right now? And then what are the barriers that we need to take down to further increase coverage? But right now, coverage hasn't moved in adults. So we have a lot of room to grow.
Claire Hannon.
Thank you. This was a great panel. I just wanted to emphasize some of the points that were made by the panel around the funding for vaccine and, the great work that was talked about being done in Denver and in Colorado and local health departments and state health departments all over to vaccinate uninsured adults. But they just don't have enough money to purchase vaccine. The Section 317 program has not been increased anywhere near the need or the inflation or to cover additional vaccines that have been now recommended, such as hepatitis B, now a universal recommendation. And Mitch mentioned Section 340B, I think it was. That program, I think, supports FQHCs, but again, there's not enough funding to purchase the vaccine in these programs that are really great, doing great work, and could vaccinate more people if there were additional funding. So the vaccine for adults program was mentioned, and just to say what a need there is for that.
Justin Mills.
Thanks. There's been a lot of discussion that came up a couple of times around the USPSTF and their recommendations. I'm one of the medical officers who works on that team. And so I just wanted to clarify a couple of things. We do understand that there is a discrepancy between the CDC and the USPSTF recommendations on hepatitis B screening for adults in general, and adolescents and adults. But there is a positive recommendation for pregnant persons, and then also for hepatitis C, there is screening for that as well, a positive recommendation. As you know, the task force, makes their recommendations based on the evidence that they have and does not consider coverage or insurance coverage in their recommendations as they make them. And one of the issues that they came across when they were looking at the evidence of hepatitis B screening was that a lot of the screening evidence was in high-risk populations only. And so I believe they've called for more research in that area, and hopefully in the future they'll be able to have more information and maybe make a improved recommendation or a different recommendation. So.
Thank you for that. I think I will comment there, if I may, that simply that highlights the importance of, even though in the ideal setting, we might want to see screening and vaccination done concurrently, if we can perhaps achieve higher vaccination rates by uncoupling those for people who are at low risk and not currently recommended by USPSTF to be screened, that people should feel free to continue to vaccinate every person through age 59 and screen where it's appropriate under current recommendations. But trying to couple these two together, I think, is creating some challenge because the screening recommendations are different. And so uncoupling and doing what we can now and circling back to screening where we need to among the low risk, if that becomes a recommendation of USPSTF, may be an important thing to consider.
And just to comment, taking the chair's prerogative, uncoupling and giving that vaccine to those that we haven't screened gives us an opportunity to reduce the number of people that fit into that high-risk population as well. Jewel Mullen, please.
I also appreciated every presentation and was wondering your thoughts about whether or not we're doing enough to convey the importance of vaccination, not just for the prevention of an acute or chronic hepatitis B infection, but for the prevention of chronic disease, chronic liver disease, and cancer. So obviously, you start with wanting to reduce the incidence and prevalence of Hep B. But when it comes to not just building confidence, but maybe increasing motivation for vaccination, both on the provider side and the public side, I'm just interested in whether or not you think there's other messaging that we also need to engage in.
I'll start, and others online may also have comments, but I completely agree that although HPV vaccine advocates try to take the mantle of being the first cancer prevention vaccine, they are not. The first cancer prevention vaccine is hepatitis B vaccine. And I think we really need to tap into our colleagues who are oncologists, who are cancer advocates, because they bring a different level of energy to this campaign. And I think if we're going to reach a wide population, people who don't perceive themselves personally at high risk, for a lifetime of protection. You never know when you're going to be at risk at some point in your life. You go to help a child who skins their knee on the playground and you don't know that child, you could be exposed to blood. It can happen anywhere at any time. And being protected and that cancer prevention message just is something that it's a problem you can fix and forget about. And we need to leverage every tool to prevent every cancer diagnosis.
Well, thank you very much to the members of the panel. Don't see any additional questions in the room. Are there any online? Okay. With that, I want to thank the members of the panel, and I know Dr. Moore has to catch an Uber, but thank you all, and we will now move to break. But first, a round of applause for the members of the panel. All right, thank you. We're going to take a 15-minute break. We will return promptly at 10:45 for Risk Less, Do More, an overview of the new evidence-based campaign from HHS to prevent respiratory illness.
Produced by the U.S. Department of Health and Human Services.